today's Grand Rounds is very special in two ways. It is an event to commemorate a dear colleague who passed away, and his family initiated a lectureship in his name. And second, we always choose highly selected speakers, and today's speaker is very special and unique. So I'm very grateful that came. The person that we are honoring his memory is Dr. Reddy, who was born in India and obtained a medical degree there in India. And after internship in India, practiced internal medicine in India and Nigeria. Got internal medicine residency when he moved to the United States at French University in Chicago, and then moved down to Shreveport for allergy immunology fellowship in the program here from 95 to 97. He was a member of our two large organizations, the American Academy and the American College, as well as the American Medical Association. He practiced in the area in Bossier City since his graduation until his departure from this world in June 2008. And his departure certainly is not just a compliment, but truly was a loss, because he was unique in his family as well as to his patients. He always treated any person without asking for any compensation, a unique quality in physicians, and I hope you young students and residents will learn from that our profession is more humanistic than materialistic. Following his death, his wife, Dr. Sobha Yaturu, who was a professor of endocrinology at the VA hospital here and the LSU, offered a generous donation to establish the endowed professorship in memory of her husband, whom she said he was grateful for obtaining his allergy immunology training at LSUS. She also donated to our section several equipment from his office and supplies that we used it. The school, together with the university, established a matching amount of money to have this professorship to be permanent. Dr. Yaturu, after she was working at the VA, she moved to Albany and maintained to come to attend this lecture. Unfortunately, this time, after she made the reservation, she could not. She had an obligation in her new place in North Carolina, the VA hospital there. She regrets that she could not make it. She was married to him nearly 30 years that she described as the best years of her life. She also considered herself very fortunate to have shared her life with a man who literally said that made every single moment they shared very special, and this was witnessed by their friends. They saw that clear. So it is very fitting to choose a person to be for this special occasion. Professor Roshini Abraham was a professor of medicine, laboratory medicine, and pathology. She's the director of Cellular and Molecular Immunology Lab, director of the Jeffrey Model Foundation Center for Primary Immunodeficiency at the Mayo Clinic. She is one of the exceptionally highly educated person that I ever met. She was born in India, and she had her basic education in India. After the BSc, she got master's in microbiology and PhD in immunology in India. She got a postdoctoral fellowship when she moved to the United States at Mayo Clinic. and took another fellowship in clinical biochemistry and immunology, also at Mayo Clinic. She has certification by the American Board of Medical Laboratory Immunology. She got awards, numerous, some of them were in India as a junior researcher. She had the Junior Research Fellowship in Biotechnology from the government, and also when she became a senior researcher from the government. In the United States, she got the postdoctoral fellowship in Juvenile Diabetes Foundation. She got the George Granis Award of Excellence in Research and Scientific Publications by the National Academy of Clinical Biochemistry. She's awarded the Outstanding Scientific Achievement by a young investigator at the American Association of Clinical Chemistry. And she got the Doctorate Award from the Association of Medical Laboratory Immunologists. She's a fellow of the American Academy of Allergy, Asthma, and Immunology, a member of the European Society for Immunodeficiencies, and president of the very prestigious society, the Clinical Immunology Society. The national international research collaboration, she is very generous in that regard. Her papers are full of names from various institutions. She extends her help, assistance everywhere. She had significant contributions to clinical and laboratory immunology by an exceptionally large number of publications. She's certainly a role model. I admire her greatly as a young investigator, role model for perseverance, success, and very, very pleasant, kind personality. She helped us several years ago when we encountered 2 children with congenital hypogammaglobulinemia. All the clinical and laboratory findings that we found compatible with X-linked protein tyrosine kinase deficiency, but the laboratory did not match with the clinical findings. So she helped us in discovering novel mutation in these 2 children. So it is great to have you, Roshini, with us here, and she is going to speak to us about laboratory evaluation of primary immunodeficiencies, which is advancing markedly, so keeping up with the times. Last week, I introduced by my grand rounds for her talk by telling you that just all what we need from you is to suspect immune deficiencies, how the history and certain physical findings can raise the red flag on a patient. By doing this, you are giving an opportunity for the patient to be well diagnosed by the immunologist, and many diseases that were fatal in the past are treatable nowadays. And this group of diseases is expanding markedly. And please welcome with me Dr. Roshini Abraham. Roshini, it is a real pleasure to welcome you, and we'll give you the plaque for this occasion. Thank you. Thanks. Let me get your presentation.
Can you hear me at the back of the room? Well, thank you very much. It's a privilege to be here to deliver this lecture in memory of Dr. Reddy, and I appreciate the invitation from Dr. Varner, who, as you've heard, I met on the phone a number of years ago and collaborated with. I met him in person, actually, only a few months ago in March of this year. Thank you very much for your hospitality. I got the opportunity to meet some of you last evening. It's wonderful to be here. I bring greetings from the Arctic Circle, which is where I live, in Mayo, Rochester. And I actually love the weather here. I wouldn't mind staying on. So I don't have any conflicts of interest, and I think I would sort of summarise the learning objectives that I hope to sort of achieve today, is to talk to you a little bit about the diagnostic tools and the presentations of PIDs, which is primary immunodeficiencies. Clearly, it's a very vast topic. It's like asking to hold the ocean in a teacup, but I'm going to try and do justice as I can. And I also want to talk a little bit, which I hopefully will convey, about the topic of test utilisation, identifying the right test for the right patient at the right time. Given that we've got a bit of a mixed audience here, I'm going to have a few introductory slides, and then what I hope to do is use two cases to sort of talk about the advances in diagnosis of PIDs. So in general, when we think about immunodeficiencies, we think about congenital inherited disorders of the immune system, and that is what they are. But you could also have sporadic mutations that arise de novo in an individual's germline that's not inherited. And of course, then if it's in the germline, that individual can pass it on to subsequent generations. So taking a family history is absolutely essential, but it need not always be informative, particularly if you've got a de novo mutation. And for a long time, people thought about immunodeficiencies as an infection-susceptible phenotype, and I think that's still true. But we've certainly expanded our thinking, because now we have a number of immune dysregulatory disorders where the presentation might not be an infection phenotype, but it could be autoimmunity, it could be some other form of immune dysregulation. So while infection is important, I think the recognition that you can have autoimmunity with a primary immunodeficiency. If you look at all immune deficiencies, at least a quarter of them are associated with some form of autoimmunity. And then, of course, depending on the specific genetic defect, there are much higher incidences. Of course, you also see susceptibility to malignancies and so on. Now, one of the cases I'm going to discuss today will talk about immunodeficiencies in the context of a syndrome. That is, you've got more than the immune system affected, you've got other organ systems affected, and that has to be kept in mind. I think clinically, from my interactions with clinicians at Mayo and around the country and the world, is that it's really challenging because it's very heterogeneous clinically. As those of you who work with these patients would understand, it's immunologically heterogeneous and, of course, now genetically heterogeneous as well. And over the years, when I've talked to physicians, they tell me, particularly the adult physicians, that we're unlikely to encounter a patient with a PID in our practice, and that's no longer true. While individual immune deficiencies might be rare, collectively they're not all that rare. They're about 1 in 2,000. And I think herein lies the challenge. We've gone in the last probably decade from about 150 molecular defects to about 400. And we're adding about 10 to 15 new genetic defects every year. It's almost impossible to keep up with it unless you live and breathe immune deficiencies. So that adds to the difficulty in identifying these patients and certainly managing them. A long time ago, we had a very simple classification for primary immunodeficiencies. We had 4 major categories depending on the type of immune defect. A few years ago, we have this more elaborate 8 different categories, and you can see things like defects in innate immunity, autoinflammatory disorders that were not previously considered under immune deficiencies have really been brought under the PID umbrella. But if you look at all immune deficiencies, 2/3 of them are B-cell defects. The pure T-cell defects are much rarer, about 5%. You've got about 15% combined defects, and then the others are of the innate immune system, which includes complements. But if you were to think about clinically how a patient might present in this day and age with an immune deficiency, they could present with an infection phenotype that probably most of you would be thinking about. But I want you to think about the others as well, the unusual autoimmunity or the immune dysregulation, where there isn't much of infection, but you have either multiple autoimmunity, recurrent autoimmunity, and so on. In some cases, it might be a laboratory phenotype where you do some laboratory studies and identify an immune deficiency. I already mentioned that you could have syndromic disorders, and if you're familiar with certain syndromes, then you know to suspect an immune deficiency with those. A few patients would come with a family history, and then of course we've got the advances in genomics, and we identify patients now with whole exome sequencing, where you don't have a very clear phenotype and genetic testing's ordered. But the issues to consider, I think, that are confounders in the diagnosis is what I mentioned, the explosion in molecular defects in this field. And some of these are associated with Mendelian susceptibility to a single microorganism, or a single group of microorganisms. For example, Mendelian susceptibility to mycobacterial disease, and there are 8 genetic defects, and we're still adding to them. Same thing with EBV. The hypomorphic, the partial loss of function mutations in the genes that we typically associate with, for example, severe combined immunodeficiency, can present later in life and have autoimmunity rather than infection. And then we see somatic mosaicism, that is, you could have populations of cells that could have reverted from the germline mutation, and that modulates the phenotype. So if you thought of PIDs as black and white, now add all the various shades of grey. We could probably put Sherwin-Williams to shame in terms of the real spectrum. And then you've got the 2 hit hypotheses. So you've got an underlying germline defect. The patient chugs along for a while and then gets an infection or some other trigger which then reveals or unmasks the underlying mutation. And then most recently, we've got the phenocopies, where there is no germline defect, but you've got autoantibodies to cytokines. For example, autoantibodies to interferon gamma and susceptibility to mycobacterial disease, or autoantibodies to IL-17 and susceptibility to chronic mucocutaneous candidiasis. They are phenotypically indistinguishable from those patients who've got germline defects, but your management would be entirely different because you treat them with B-cell depleting therapies like you would a number of the other humoral autoimmune defects. So here and now in 2017, we've got a lot of different diagnostic tools at our disposal to identify these patients. Flow, of course, is the sort of foundation of our existence. We use flow assays for immunophenotyping, for functional immunological studies, and there's a lot you can do with that with fairly small blood volumes. For soluble markers that are of interest, we have immunoassays, we do cell-based studies, we have non-genetic molecular tests that we use when appropriate, for example, to look at thymic function or T-cell repertoire diversity and so on. And then, of course, we've got genetic tests because we're dealing for the most part with heritable disorders of the immune system and, of course, chromosomal studies. I think without a doubt, anybody who works in this field would say that appropriate diagnosis is life-saving for many of these immune deficiencies, and it also allows us to prognosticate and clinically classify these patients, which we couldn't otherwise. And our approach to therapy has changed. I mean, it's not just B&T or hematopoietic transplant and IVIG. Now we're repurposing drugs that are being used in other areas for PIDs as we understand the molecular diagnosis. So obtaining the correct diagnosis is very important because you can then customize your management for the patient. So now, having given you that bit of introduction, what I'd like to do is focus on 2 cases, and then hopefully you'll get a bit of a notion about how we use different diagnostic tools for the management and identification of these patients. So this was a young child that we saw at Mayo about 1.5 or 2 years ago. She was 4 years old at that time, and she's from the Middle East. And like a number of Middle Eastern countries, you see patients who come from consanguineous marriages, so her parents were first cousins. And her main problem when she came to Mayo was that she had recurrent pneumonias. And while she was at Mayo, we isolated Burkholderia from a tracheal aspirate, and she also had a serratia infection from a BAL, and she had some evidence of bronchiectasis. In addition to all these pneumonias, she had myoclonic epilepsy, and she had a sister who had the same thing. So she had whole exome sequencing, and there was a variant identified in this KCTD7 gene associated with myoclonic epilepsy. But we were involved because from an immunology standpoint, she had these recurrent pneumonias and she had these unusual organisms, Burkholderia and serratia. And for those of you who do immunology, those organisms kind of raise a red flag and suggest a diagnosis to you. And so we thought about the same thing. We thought she might have chronic granulomatous disease. So I performed the neutrophil oxidative burst test for CGD. And when I first reviewed the results, I looked at the patient's results, I looked at the control. At that time, the first time around, I hadn't tested the father. And she looked normal, low normal, but still normal. So I said this is unlikely to be CGD. I know she's got these organisms, but her DHR test is negative, and it's a very sensitive test, and it's considered fairly specific. There are some other situations where you could see an abnormal DHR. So I said this is not CGD. But we went ahead and did whole exome sequencing on her. And we found a mutation in this gene, CYBA, that encodes a cytochrome protein that's part of the NADPH oxidase complex in neutrophils. So then I had to take a step back and think that I could be wrong in my assessment of the DHR result. And I went back and repeated, and I asked this time for the parents' samples as well. The mum was not available, so I got the father's sample, and so the father looks pretty robust and good. And again, I repeated the child, and she looked normal. And the only thing I noted was that her mean fluorescence intensity was about half of that of her father's. So I was scratching my head here because she's got a homozygous variant, and it's a novel variant in this gene associated with CGD, but she's got this so-called normal DHR result. What's going on? So I decided to do specific protein analysis to see whether she had the specific protein encoded by that gene, which is the P22 FOX protein. And as you can see, her histogram's in the red with the arrow, and she's lower but not absent compared to healthy controls or her father or mother. I sent a sample to my colleague, Dr. Steve Holland at the NIH, and asked him to do a Western blot to look for that protein and the other protein, which is the GP91 FOX over here. If I can find it, there it is. Because those two are membrane proteins that are associated together. And so if you don't have one, you don't have the other. And you can see that she's abnormal for GP91 FOX as well. So clearly, this mutation was doing something to her P22 FOX. So I revised my opinion of the DHR results, and I said this has to be consistent with CGD. And as a matter of fact, we're doing some additional functional and biochemical studies to characterize that. But one lesson that I took home from this patient that made me change my mind a bit with regard to the DHR test is you can't be absolute. The DHR test is indeed a very useful test, but you have to look at it in the entirety of the picture, which includes the clinical phenotype. The only thing revealing was that, because I had the father as well, is that her mean fluorescence intensity, the amount of NADPH oxidase activity, was half that of the father. But she definitely had lower protein expression. And so we decided to treat the patient as having chronic granulomatous disease. So I'll come back to the lessons that we need to keep in mind from this patient. But I just want to take a step back. And for those of you not familiar with CGD, just provide a little bit of background. So neutrophils are, of course, part of the innate immune system. They're critical in managing the acute sort of insults to the immune system. And there are three different mechanisms that the neutrophils use in managing microbial pathogenesis. One is, of course, the enzyme-related NADPH oxidase-dependent killing, activation of specific proteases, and formation of NEToses, or these neutrophil extracellular traps. So these are really extrusions of chromatin, which have these specific cytoplasmic as well as granule proteins, and they're really used to trap microbes and bring it in. So NEToses is good for the immune system from the standpoint of controlling infection, but it's not so good when you think it participates in the pathogenesis of autoimmunity and inflammation. So that's your NEToses. Those are your chromatin fibers with all these specific proteins that entrap these microbes. And a number of neutrophil granules. That's why the neutrophil looks very granular when you look at it under by flow cytometry. It's got a number of these granules that contain these various enzymes and proteases. So when a microbe binds these specific receptors on neutrophils or other innate immune cells, the phagosome that is formed then fuses with the lysosome that contains all these killing proteins, if you will. And this phagolysosome is really where you're conducting this NADPH oxidase-dependent killing through the production of these reactive oxygen species. Now, when we think about CGD, unlike with most other PIDs, we have one clinical label with a number of molecular defects under that. And so CGD is the same. It's not a single gene defect. It's a 5-protein complex that forms the NADPH oxidase. And all of those components, the 4 of those 5, are absolutely essential for generation of this killing machine, which is superoxide production. And so you get hyperhalous acid, you get hydrogen peroxide, and of course superoxide being formed. So if you've got defects in any of the components of NADPH oxidase, it affects all mechanisms of killing. And what I'd like to point out is the patient had a mutation, a homozygous mutation in the CYBA gene, and I told you that it associates with this glycosylated 9-to-1 FOX protein on the surface, and that's why if you've got a mutation 1, you don't see much of protein expression in the other as well. And so what you're really getting is the formation of, bleach and hydrogen peroxide, and, that's pretty good. We use it to clean the bathroom, so no reason why we can't use it in the body. So there are 5 different genes associated with CGD. And the incidence is variable, but I think in the US it would be reasonable to say that's about 1 in 250,000. And the X-linked form, that is the mutations in the CYBB gene that encodes GP91 FOX, is about the most common. That's about 70%. Now, what's unusual about the X-linked form of CGD is you see a huge rate of skewing of lionization. For those of you not familiar with what lionization is, it's X chromosome inactivation. And normally that's a random process, but there's always a selective advantage to keeping the good and eliminating the bad. And unfortunately, for reasons not quite clear, there's this rate of skewing of lionization where you keep the bad and eliminate the good, and so female carriers can be symptomatic. And the patterns of lionization change with age. So a woman will change her lionization pattern. So if you're a carrier and you're asymptomatic, that doesn't mean you stay asymptomatic all your life. You can become symptomatic over time due to changes in lionization patterns. So there are the other 4 NADPH oxidase genes associated with this autosomal recessive, and 3 of those account for 30% of the cases, and there are a whole gamut of mutations affecting all parts of the gene, resulting in all kinds of mutations. I already talked about the fact that you see skewing of lionization, so that's a situation where a female carrier for an X-linked disease can actually be symptomatic, and you have to think about it. Now, data published from the NIH a very long time ago said that if a female has at least 10% functional neutrophils, she won't be symptomatic. And I don't think that's true any longer, because I've seen patients who've had up to 30% functional neutrophils who are symptomatic. So again, you know, some of these paradigms that were devised a long time ago are being challenged by new data. So the age of presentation, the oldest patient who presented was an article in the New England Journal of Medicine a number of years ago, was 65. And he had a hypomorphic, a partial loss of function mutation. So you typically expect early presentation from the completely null mutants, and these partial loss of function can show up at any time. And of course, you know, for those of us who deal with PIDs, you know, we're used to a certain classic presentation of PIDs. We see the classic abscesses, granuloma formation, and of course, a subset of those patients have inflammatory bowel disease with colitis that is indistinguishable from just regular IBD. So you have to keep that in mind. You also see some unusual infections, unusual pathogens, Serratia, Burkholderia, Aspergillus, Nocardia. So that's something that allows you to think about CGD in your differential. And you see this exuberant hyperinflammatory response. And in fact, you should be very careful in treating IBD in these patients with anti-TNF agents, because you can actually exacerbate their disease and also exacerbate their susceptibility to infection. So from a laboratory perspective, how do we diagnose? This is for the old school. We're 21st century, so we don't use this in our lab anymore. But there's certainly labs around the world and a few labs in the US that still use this NBT, nitroblue tetrazolium test. The disadvantages are that it's a subjective test. It all depends on the experience of the reader. And so what it looks at is a color conversion on a slide. So you're basically looking at the ability of neutrophils when stimulated to oxidize this particular chemical that you're using that becomes a blue dye, and then you count the number of neutrophils with the blue dye. So you can imagine that it's somewhat subjective. So the DHR test, the dihydrorhodamine test, has become probably the most popular test for CGD. And it's really quite good in terms of its sensitivity and specificity. So DHR is a non-fluorescent compound, and when you stimulate neutrophils and they mount an oxidative burst, that will result in the production of a fluorescent compound, rhodamine 1,2,3, and we can measure that fluorescence, the green fluorescence, by flow cytometry. So we use a chemical, a mitogen, to stimulate neutrophils in vitro, and then we measure this oxidative burst. Now, I told you that the NBT test was subjective. And while the DHR test is not quite as subjective as NBT, it certainly does require some expertise in interpretation, because it's about pattern recognition as much as it is about numbers. So if you look right up here, this is normal, and this is unstimulated. So you don't expect much NADPH oxidase activity when the neutrophils are quiescent. You activate them, that DHR is converted to this fluorescent rhodamine, and you can measure that. Okay, so that looks excellent. That individual, thankfully, doesn't have CGD. So if you've got X-linked CGD with a completely null mutation, you've no oxidative burst, and those two peaks would overlap. Excuse me. But if you've got these autosomal recessive forms, the pattern looks quite different, and you can use the pattern to sort of key you towards a particular molecular diagnosis. For example, mutations in the NCF1 or NCF2 gene, can you see that you have a subset of neutrophils that produce a wee bit of oxidase activity? So that's what we call a dim fluorescence. But pattern recognition, don't make categorical assumptions, because here's a patient that I thought initially had autosomal recessive CGD just based on the pattern that there was oxidative burst, but it was very minimal. It turned out to be a hypomorphic X-linked CGD. And then this is complete myeloperoxidase deficiency. So this can give you a false positive result for an assessment of CGD. So myeloperoxidase is also needed for oxidative burst. And if you've got complete MPA deficiency, all the neutrophils will have some oxidative burst, but it will be quite low. And it's very easy to pick this out. You can just stain these neutrophils from these patients for myeloperoxidase. Partial myeloperoxidase deficiency cannot be picked up as a false positive, but complete can. And most of these patients are asymptomatic, but a subset of them can have significant infection, also associated with candida and type 2 diabetes. And then this is another case that threw me for a loop. So I was reviewing a DHR result, and I looked at the pattern, looked like beautiful X-linked CGD, but it was a 6 to 5 year old female. And so I thought to myself, that's strange. So I called the infectious disease physician, and she was admitted to a nursing home. She had a hip replacement, and she had developed Burkholderia pneumonia. And he was sharp enough to put her history together and her clinical phenotype and order the DHR test. He knew from taking her history that she was a carrier for X-linked CGD and had a son with X-linked CGD. So he immediately thought about whether she might have skewed lionization with age, and he ordered it, and I told him that that was indeed the case. She had 100% skewing of lionization with age. And so she was a carrier, and her pattern had changed over time. Now, what we have in the lab is this NADPH oxidase-specific protein flow. So if we identify a patient with an abnormal DHR test, before we recommend genetic testing, we can use this specific protein flow to narrow down what the potential genetic defect might be. And I've used it, and these are some practical examples that I'm going to show you. So this is the first two sets of graphs here are healthy individuals looking at either neutrophils and or monocytes for the GP91 FOX protein, the P22, P47 and P67. Normal people, everything looks beautiful, the red peak, very normal. Now here was a patient who was referred to me from Michigan. He was a young boy who actually had early onset inflammatory bowel disease, Crohn's. He had no infectious symptoms, but you have to put CGD in the differential for early onset bowel disease, and he was sent to me. He was abnormal on the DHR, but he didn't look like an X-linked CGD. He looked either like autosomal recessive or an atypical X-linked, and he turned out to have an intronic mutation. It was a novel mutation in the gene encoding the GP91 FOX. And I picked it up because he has no CYBB protein, no GP91 FOX. So I told the physician that that mutation is indeed pathogenic because he doesn't have the protein, and that explains his abnormal DHR result. This girl here had some oral ulcers. She had a brother who had some evidence of some ground glass opacities in the lung. And the DHR was abnormal. To identify the specific genetic defect, I did that, and it turned out that they had no NCF1 protein, P47 FOX protein, and they turned out to have the most common 2 base pair deletion in the NCF1 gene. Phenotype, pretty non-specific, no significant infection, no IBD. Whereas in this patient, this is a 14-year-old from St. Louis, Missouri, who presented at the age of 14 with Crohn's, no infection. And the physician who sent him to me was an immunologist and said she suspected an X-linked disease. But after doing this, I said, no, he's got an NCF1 gene mutation because he has normal CYBB protein, but he has no P47 FOX protein. So we can sort of triage the potential molecular defect by doing this specific protein flow. So here are some take-home lessons from this case. One is a normal oxidative burst does not always mean there isn't CGD. You've got to interpret it in context. The first patient had the Burkholderia pneumonia, she grew out serratia. So you've got to say that that is not common, and say that allowed us to take the DHR result in the light of the genetic testing and do the additional studies and say that this is indeed a pathogenic CGD mutation and we could treat it appropriately. Otherwise, we would have completely missed the boat, and I missed the boat as well. And I learned a lesson from this patient, and I hope that that will be informative. So communicating the clinical phenotype to the laboratory is very helpful. I get samples from all over the country and I don't always get the clinical phenotype. So I encourage clinicians who use this testing to communicate with the lab about the clinical phenotype, because that changes the whole complexion. It certainly directs genetic testing. And we have to keep in mind that we once upon a time identified the blacks and the whites, but we now have the knowledge and the ability to look at all these shades of grey. And so you will have patients who are atypical, who challenge your conventional paradigm, but you have to think about it. And then, of course, the specific protein flow allows us again to look at these patients who have unusual presentations and then tell the physician that you can do targeted genetic analysis. Now, in the last 10 minutes or so, I want to give you another case that again challenges, the way you would think about it clinically, and certainly even challenges you in the laboratory. So, as you know, newborn screening for SCID has been implemented in about 47 of our 50 states. So from the time we started in 2010, we've got most of the states in the US doing newborn screening for severe combined immune deficiency. And for those of you not familiar, we really look at a small byproduct, a DNA byproduct produced by T-cell receptor rearrangement that sort of tells us the proportion of T-cells as the thymus is functioning normally. And then, of course, if you get an abnormal result, you do additional studies. And so, just for those, the residents and the fellows who may not be that familiar with SCID, again, it's a label, but we've got a number of molecular defects nestling under that clinical term. We've got about 19 different genetic defects associated with SCID, and we are adding to that list. And of course, the T-cell lymphopenia and or T-cell function is one of the key characteristics of SCID, but they could have numerical deficits in B cells, NK cells, etc. They're all asymptomatic at birth. Usually the median age of symptoms are 4 to 7 months. And of course they have all the characteristics of a classic cellular immune deficiency, failure to thrive, opportunistic infections and so on. And of course treatment is critical. So in the typical SCIDs, if you transplant them before 3.5 months of age, you have a 94% long-term survival. If you transplant them after 6 months of age, that drops to about 60%. But what we've realized from newborn screening is we're not just picking up SCID, we're picking up other conditions. We call these secondary targets. And so now you have to broaden your differential because you have patients who don't look quite like SCID. And so in Minnesota, we started doing newborn screening in January of 2013. And a few years ago, this baby had an abnormal Minnesota newborn screen. She's from North Dakota, but they weren't doing it at that time. And so she was referred to me for additional laboratory follow-up. I noticed that she also had B-cell lymphopenia and she had NK lymphocytosis. Usually when you've got T and B lymphopenia, you can see a homeostatic expansion of NK cells. But it wasn't as convincing as to call her SCID. So something funny was going on there, but it wasn't typical SCID. So we decided, let's not rush to judgment here. Let's just monitor her for a bit. But it was progressive. Her T and B cell lymphopenia was progressive. Her immunoglobulins went down and didn't really recover, so we put her on IVIG. Her M and A were low as well. And when I looked at her thymic function and her T cell function, which is this set down here, she had some thymic function, but it wasn't perfectly normal, it wasn't completely abnormal. So she was in that, I don't know what she is, bucket. And again, she had some normal T-cell function at times and she had abnormal at times and so on. What I found interesting was right from the beginning, she had elevated alpha-fetoprotein. And some of you, that may already make you think of a particular diagnosis, but some of you may not think of a diagnosis. But the problem with the AFP is that the reference range is not usually designed for very young children and infants, so you've got to monitor them, and she was persistently elevated. Now, she was a child of a second union, if I may put it that way. So her father had other children, and then with this particular partner, he had her and a couple of other children. So she was the only one symptomatic from either compared to her half siblings or her full siblings. So with the alpha fetoprotein, so our key conundrum was, do we transplant or not, BMT or not? We decided we couldn't rush to BMT because she didn't fit the SCID bucket, and we needed a specific molecular diagnosis because BMT might not be indicated. So we sent the conventional SCID genetic panel, and she was negative for the classic genes. So we decided we'd do whole exome sequencing, and of course the alpha fetoprotein suggested ataxia telangiectasia to me. But we did the whole exome sequencing, and she did have a mutation in the ATM gene, but it was a heterozygous mutation that she had from her father. Her father had exactly the same thing, he was asymptomatic. So I knew that that couldn't explain her phenotype, because she had evidence of immune deficiency. She had the same heterozygous variant as her dad, but didn't have that phenotype. So for those of you not familiar, AT is a syndromic PID. You've got the neurological issues, the cerebellar ataxia, the ocular telangiectasias, but you've got the immune deficiencies because it is a mutation in a gene that encodes a protein important for DNA repair. And lymphocytes need DNA repair, and that's why she had T and B cell lymphopenia, but nothing affecting her NK compartment. Now, there's not much you can do for AT. You can't do a bone marrow transplant for AT. But the problem was she AT or not? Because she had a heterozygous variant. This is an autosomal recessive condition. So there wasn't any clear genotype-phenotype correlation. There was some evidence that she could have a AT phenotype, but it didn't all add up. So I realized we needed some additional data. There's no clinical laboratory in this country offering a rapid test to measure radiosensitivity and DNA repair defects. There's only one lab in California that takes 9 months to give a result. So that's not really practical. So I decided that I would develop a flow cytometric assay to look at the function of some of these key proteins involved in DNA repair. So ATM is a protein that gets autophosphorylated when exposed to low-dose radiation in lymphocytes. And once ATM is phosphorylated, it phosphorylates several downstream proteins that ultimately results in DNA repair, cell cycle arrest, and so on. So there wasn't anything available, so I decided to put together a panel to look at native protein and phosphorylated protein when I subjected the lymphocytes to low-dose radiation. So here's mum and dad and the control and the patient, and she has normal native protein, so no problem there with her ATM protein. But when I irradiate her lymphocytes and look at phosphorylation in T, B, and NK cells of the ATM protein, you can see that she does not phosphorylate ATM. She should. Normally, if her ATM was functional, if that ATM protein she had was functional, she should have phosphorylated like her mum and dad. And her dad had the same heterozygous variant. But he was behaving differently from her, which suggests that there was a functional defect that was not entirely explained by the genetic diagnosis. At 1 hour post-irradiation, we see maximal phosphorylation. And you can see the controls, mum and dad, all look great, but she doesn't have any phosphorylation. There's another protein, a histone, called H2AX, that gets phosphorylated when cells undergo DNA damage due to irradiation or other conditions. And when the histone is phosphorylated, we call it gamma H2AX. And it's phosphorylated by ATM and by ATR. And so a number of labs focus only on this particular protein. And if you look at the frequency or the percent of lymphocytes that phosphorylate, she looked normal. She's the last bar here. She looked normal. But when you actually look at the amount of phosphorylated protein, she was half that. Why? Because H2AX is phosphorylated by ATM and ATR. So that's why she looks normal when you look at the percent or frequency. But because she's lost 1/2 of the pathway, the amount of protein phosphorylated is half. So again, telling you that you can't use standard assumptions. You have to look at the amount of protein being produced, amount of protein being phosphorylated. We also looked at the kinetics, because normally we phosphorylate maximal peak at 1 hour and we come down by 24 hours. She, of course, did not phosphorylate at 1 hour, so she didn't show any of the normal kinetics. So what was clear from this assay, so I only showed you ATM, but I looked at a number of downstream proteins and they were all abnormal in phosphorylation in her. So clearly, without a doubt, she had a functional ATM defect. But my challenge was trying to explain why she looked different from her father, given that she and her father shared a heterozygous variant. So clearly, whole exome sequencing did not do the trick. So we decided to do RNA sequencing to see if there was a cryptic second mutation that we were missing. And so that's what we did. And what we found out was actually she did have, on the other allele, a novel fusion between ATM and a neighboring gene, resulting in a chimeric fusion protein between ATM and this other protein product that we have no biological function for. But you see, why did she have normal native protein? Because the antibody that recognizes native protein is in the portion that was not affected by the fusion, whereas the antibody that recognizes the phosphorylated was within that chimeric or fusion protein. So this clearly established that both her alleles were affected for ATM. This was deep in the intron, and that is why we didn't pick it up by exome sequencing. So she was actually a compound heterozygote because her mum had exactly the same fusion. So she inherited a maternal novel fusion, and she inherited a heterozygous frameshift mutation from the father. So she got a double whammy, autosomal recessive. She was a compound heterozygote. So it wasn't a de novo mutation, it was maternal. So in summary, the diagnosis of PIDs, I hope these two cases showed you that it's pretty complex. You know, the straightforward cases, maybe we still miss them, but they're not that hard to figure out. But it's these atypical patients who challenge your prevailing concepts. But if you utilize the right tools and you think about the right things, you would be able to identify these patients. The first case certainly showed us it's important to synthesize the clinical phenotype, because if we had depended only on the laboratory result and not the clinical data, I might have just said, don't bother, she doesn't have CGD. But now we've got a novel variant in the CYBA. It tells us something about the biology of that mutation with regard to CGD. So that's why we're doing the additional functional and biochemical studies. The second case tells us that we need to really broaden our diagnostic armamentarium. There wasn't a test for flow-based radiosensitivity or DNA repair, and certainly if you're considering bone marrow transplant, your choice of conditioning regimen, you need to know if somebody is radiosensitive. If you wait 9 months for a lab result, you're really not going to help you at all clinically. So we had to come up with a new test that we could utilize in the clinical lab to figure out these sort of patients. And we're certainly finding a lot of this because of newborn screening. You know, we're finding patients with novel variants of uncertain significance by genetic testing, and you need functional data. So don't settle for easy answers, because the patient drove us to develop a new diagnostic test. And then you might have to do additional molecular studies like we did RNA sequencing. So the clinical laboratory is actually indispensable for diagnosis of these PID patients, but unfortunately I see tests being misutilized, wrongly ordered all the time. So I think it's very, very important. I'm a bit of a test utilization fiend because these tests are very expensive, complex, difficult to interpret, and it doesn't help you if you order the wrong test for the wrong patient or at the wrong time. So, you know, the interaction between the clinical laboratory and the physician is important in making the diagnosis. This is just a little tool for the residents and fellows. I'm not entirely sure what that is, but just a little key that you could have handy to help you with identification of these patients. This is our Mayo workup. We use a clinical consult plus minus a lab consult depending on the case. We do a pre-genetic immunological workup, genetic diagnosis, and we may have to do some post-genetic workup as well. I'd like to acknowledge a number of my colleagues both at Mayo and elsewhere who worked with me on these cases that I presented to you. Thanks so much for your attention.
It was wonderful. I have a question, please.
Did you look at G6PD deficiency in this patient?
It's a very good question. So you're right, G6PD can give you an abnormal result. We didn't look at G6PD in the first case because the whole exome had revealed the CYBA variant. But yes, G6PD can give you an abnormal result on the DHR. So that's a good point, besides MPA deficiency.
We have 3 patients with both CGD and G6PD.
Okay.
Fortunately, the G6PD was of a low to moderate degree.
Okay.
Is there any role
So,
for G6PD adding to the CGD?
right, so in this case it does not appear because we sent it to the NIH. She has normal G6PD. Well, we think in this patient she has a monocyte specific defect. So there's been only one case reported with the CYBB gene that only affects monocytes and not neutrophils. And those patients have Mendelian susceptibility to mycobacterial disease. Well, we looked at oxidative burst in her monocytes and it is abnormal. So I'm working with the biochemist at the NIH who's an expert in this area to really characterize whether this might be a new defect affecting monocyte rather than neutrophil function, which explains why the DHR was normal in neutrophils, but then that monocyte defect appears to predispose her to the same infections that we see with CGD, the Burkholderia serratia. So the story is yet to be revealed with regard to this novel variant.
An important principle that we can leave with today is to avoid the frequent mistake that when we find a lab result normal and we tell the patient you are fine. Complete mistake. Advances in diagnosis and diagnostic tests, as you noticed, are remarkable. That we depend Dr. Abraham to help us in this. She helps our friends in various places. These national resources are very important rather than to tell the patient you are not sick. The patient does not get sick according to the book. The book is written from the patient. Thanks a lot again.
Thank you.